Hello, good morning everyone. My name is Dr. Bhargavi and I'm pleased to be presenting our results titled The Assessment of Mean Nocturnal Blood Glucose Levels Among Diabetic Patients Attending a Tertiary Care Center. This study was conducted with a focus on how nocturnal blood glucose trends relate to diabetic management and complications. Here's a quick overview of today's presentation. We'll be dealing with the introduction to glycemic variability and the limitations of relying solely on HbA1c. Then I'll walk you through the key studies that have shaped our understanding of glucose control. Next, we'll examine the various metrics used to assess the glycemic variability, including the time and range and tools like continuous glucose monitoring. We'll also look at the physiological factors affecting nighttime glucose levels and explore the cost effectiveness of modern monitoring methods. Following that, we'll go into our research methodology, findings, and the clinical implications. We'll end with the conclusions and recommendations. Moving on to the literature review. Historically, HbA1c has been used as a gold standard for long-term glycemic control thanks to the landmark studies like DCCT and UK-PDS. It provides a 2 to 3 month average of blood glucose and has been shown to be an independent risk factor for complications like retinopathy, neuropathy, and cardiovascular issues. However, emerging research suggests that glycemic variability, how much blood glucose levels fluctuate, is also a significant contributor to these complications. Now that we've come across the two parts of the problem, the main issue here we're going to focus on is the over-reliance of HbA1c as a primary therapeutic endpoint and not the trends in glycemic variability. Okay, so HbA1c became the standard measure of control following DCCT and UK-PDS trials, as I previously mentioned. However, no added benefit was seen when the HbA1c was pushed below 7% in terms of cardiovascular or microvascular outcomes. Notably, the benchmarks were widely established for the use of cardioprotective medications. Many patients will develop complications despite optimal HbA1c levels. This led to the researchers to believe that glycemic variability was possibly an additional risk factor associated with poor outcomes. The mean and standard deviation and glycemic variability. Mean glucose and standard deviation help assess the spread of glucose values. High variability has been linked to complications like ischemic heart disease and nephropathy. Fasting glucose variability in particular is an independent risk factor for retinopathy in both type 1 and type 2 diabetes. This slide underlines the significance of understanding the day-to-day glucose swings. Moving on to the limitations of standard deviation and better alternatives to this particular thing. While standard deviation is a useful thing, it can more often be misleading when we don't know the mean, especially. A standard deviation of 10 is very different when the mean is 50 than when it is 200. Additionally, post-meal spikes can also distort the standard deviation values. Mean amplitude of glycemic excursions improve the accuracy by focusing on significant fluctuations. Another useful metric is the coefficient of variation, which adjusts standard deviation based on the mean to give us a clearer picture. Moving on to MAGE, which is the mean amplitude of glycemic excursions. MAGE looks at the major glucose swings between the peaks and troughs, ignoring the small and irrelevant changes. It has been associated with diabetic nephropathy, cardiovascular issues, and even nerve dysfunction. While it's not directly linked to complications like retinopathy, reduced time and range often correlates with this. Coefficient of variation. This is something that addresses the drawbacks of standard deviation and MAGE by normalizing for the mean. CV below 36% is considered good control by the American Diabetes Association. It's inversely related to the time and range, meaning as the coefficient of variation goes up, the TIR goes down. High coefficient of variation is tied to more complications and is also used to guide insulin delivery systems. Continuous overall net glycemic excursions. This looks at the glucose changes over set intervals and can catch patterns like post-meal spikes. Moving on to MODD or the mean of daily differences. This measures the average difference in glucose at the same time on consecutive days. A high mod indicates erratic day-to-day glucose levels, suggesting less predictable treatment responses and outcomes. Finally, to the TIR. TIR or time in range is something that shows the percentage of day glucose levels that stay within the particular target range. This is vital because time spent too high or too low, known as the time above average or time below range, is linked to complications. The American Diabetes Association recommends spending at least 70% of the time within the established ranges. Standard amplitude glucose profile. The ACP provides a detailed look at daily glucose patterns, including the time in each range, median values, and variability. It is a core tool in CGM reports and helps clinicians assess how well patients are managing their diabetes on a day-to-day basis. is a chart to represent the same. Let's move on to the physiological factors in nocturnal blood glucose levels. Okay, this is something that is usually not influenced by meals and activity because there is some amount of baseline homeostasis or internal metabolic regulation that is going on. The key hormones which are involved in the day-to-day regulation of glucose levels include cortisol, growth hormone, insulin, glucagon, GLP-1, and GIP, and sometimes it also changes due to circadian disruption. The disruption in the cycles can cause elevated nitrogen glucose levels, and as I mentioned earlier, that is something we aim to reduce. FGM or flash glucose monitoring. This gives the glucose readings only when the particular thing is scanned. It's cheaper and has a longer sensor life than CGM, making it a more economical option. However, it lacks continuous data and real-time alerts. Continuous glucose monitoring. These systems measure glucose every few minutes, providing a complete picture of glucose trends. They're very essential for calculating key metrics like the coefficient of variation, CAGA, and TIR. The American Diabetes Association recommends them for estimating HbA1c and for all patients on insulin therapy. This slide here represents the mechanism of action of certain devices which are used in continuous glucose monitoring. Here's another thing representing the same. So we saw about continuous glucose monitoring and flash glucose monitoring, but we never really understood the exact difference between the two. So this slide here highlights the key differences between continuous glucose monitoring and flash glucose monitoring. CGM systems provide real-time glucose readings with trend alerts, enabling proactive adjustments and greater safety, especially for patients at a higher risk of hypoglycemia. They are ideal for those needing tight glucose control or insulin pump integration. On the other hand, FGM systems such as Freestyle record glucose data continuously but require manual scanning to access readings. They are more cost effective, user friendly, and suitable for patients who prioritize affordability or prefer a less complex system. Ultimately, the choice between CGM and FGM should be tailored based on the individual clinical needs, lifestyle, and financial considerations. Now we're going to move on to a part in our presentation which is full of figures, but I'll just try to simplify it as much as possible. We're going to start with the average willingness to pay thresholds. This slide reviews the concept of willingness to pay or WTP for health interventions. Each country has a specific WTP threshold, often based on the GDP per capita, that guides whether a health technology is considered cost effective or not. High income countries usually have a higher threshold, supporting the adoption of advanced technologies like CGM. When you look at this over here, you can see that the United States and United Kingdom are on the top rung of the ladder, and these countries usually support the adoption of CGM. However, in contrast, lower income countries like India, where we did the study, may operate with stricter financial limits, influencing decisions in favor of more affordable tools like FGM. Cost effectiveness of cesium by country. The slide presents data from various slides on the cost effectiveness of cesium across different nations. In countries like UK, Canada, and Germany, cesium can be shown to be cost effective based on the improved glycemic control, fewer complications, and better quality of life. The benefits often justify the higher initial investment, especially in healthcare systems with robust reimbursement models. Moving on to the next slide, we're going to talk about the cost effectiveness of FGM by country, which is more or less similar to the one we saw previously. And here we're going to compare the cost effectiveness of CGM and FGM by ICER. ICER is the incremental cost effectiveness ratio. This is a key metric in health economics. It compares the additional cost of one intervention over another with the additional health benefit it provides, typically measured in QALYs or quality adjusted life years. An intervention with a low ICER related to the country's WDP threshold is considered cost effective. Continuous glucose monitoring often has a favorable ICER in high income countries due to drug reductions in emergency care and long term complications. There is something called the WHO Choice Framework, and that's the initiative which provides global guidance on health economic thresholds. It recommends that an intervention is cost effective if the ICER is less than 1 to 3 times the GDP per capita of a country. Using this particular model, both CGM and FGM can be evaluated fairly across the various income settings. This framework supports context sensitive decision making and also emphasizes value for money in health interventions. Let's move on to the beta cell function indices. We have a couple of indices here, and talking about HOMA beta, this is something that's based on fasting insulin and glucose, and this estimates the basal insulin secretion. C-peptide indicates the endogenous insulin production and is stable even when insulin is sent. Insulinogenic index is are going to measure the early insulin response after the glucose challenge. Disposition index is the insulin secretion adjusted for sensitivity, highlighting functional beta cell reserve. ISSI2 is something that is more complex, but this is considered to be one of the most robust markers when incorporating OGTT insulin glucose area under the curve and insulin sensitivity. Okay, so we're going to talk about the inverse relationship between glycemic variability and beta cell function now. There is a notable inverse relationship between the beta cell function and glycemic variability. Higher values of coefficient of variation, standard deviation, and age are associated with lower HOMA beta and C-peptide levels. This suggests that worsening beta cell function contributes to more unstable glucose levels. The DIR or time to range positively correlates with better beta cell markers. In early stage type 2 diabetes, high GB may help predict which patients will experience a faster decline in beta cell function. Okay, so now coming to the big question, does SMBG effectively measure the glycemic variability? This was actually done in a study, and what we did was we actually took six different samples. So the fasting, pre-meal, and the bedtime readings. But we found that it actually misses the overnight and post-meal fluctuations that are critical in detecting the glycemic variability. In contrast, CGM and FGM systems provide near continuous data. Studies show that SMBG may underestimate the variability and miss nocturnal hypoglycemia. CGM and FGM not only improve the clinical accuracy but also support behavioral change by offering real-time or near-time feedback. Coming on to the other research questions or considerations that we need to think about. A common question is whether nocturnal glucose levels can reflect beta cell and hormonal dynamics without interference from meals or activity. While nighttime readings are more stable, studies suggest no strong correlation unless using continuous monitors. Another question is whether we can glycemic variability be a therapeutic target? The American Diabetes Association now says that the international guidelines support glycemic variability as a valid target. Metrics like TIR and coefficient of variation are gaining prominence as endpoints in clinical trials and practices. We'll just talk a bit more about what we did in our study. The hypothesis we agreed upon was that the higher mean nocturnal glucose levels were associated with an increased risk of diabetic complication. This stems from the evidence linking nighttime hypoglycemia with oxidative stress and endothelial dysfunction. The chronic glucose fluctuations, especially during sleep when the body's counter-regulatory responses are limited, may accelerate vascular damage and lead to micro or macrovascular complications. Highlighting some key features in our research methodology, we actually conducted a cross-sectional descriptive study. The participants were type 2 diabetic patients admitted for diabetes-related complications. We excluded those on medications that could alter glucose like corticosteroids. Data was collected using a semi-structured questionnaire in the local language. Nocturnal glucose was measured hourly from midnight to 5 a.m. using the AccuCheck Performer device, which offers reliable electrochemical readings. Fasting and postprandial samples were also collected for comparison, but extensive analysis was not carried out for the same. Our analysis and conclusion, our findings actually show that the mean nocturnal glucose levels respond more quickly to physiological and therapeutic changes than HbA1c. Patients with foot ulcers had the highest value of nocturnal glucose levels. A significant difference in nocturnal glucose was observed between those with cerebrovascular accidents like strokes and foot complications, suggesting that monitoring nighttime glucose might serve as an early warning for specific diabetic complications. We have a couple of recommendations to suggest based on our study, and it mainly has a lot of things to do with conducting more longitudinal studies to confirm the causal relationship between the night and glucose and complication risk. Incorporating glycemic variability metrics into the treatment goals, especially TIR and coefficient of variation. Enhancing the patient education on the importance of overnight glucose monitoring. So yeah, this is the end of our presentation. Thank you so much for your patience, and I thank everyone for this opportunity. We hope this research contributes meaningfully to the growing body of evidence supporting a more dynamic and personalized approach to diabetes care. Thank you so much.